One, on behalf of the Center for Primary Care, I would like to welcome you to our webinar today. My name is Megan Lenneman, and I'm the Program Manager of the Center's Education Team. And I'm here today with my colleague, Erin Farron, who's helping to facilitate. So this is our fifth webinar in our Scaling Community Outreach and Primary Care Education series, also known as S.C.O.P.E. And we're glad that you could all join us today. At the Center for Primary Care at Harvard Medical School, we're committed to uncovering, promoting, and fighting for the best and most efficient ways to deliver high-quality primary care around the world. As part of our mission, we aim to connect our community to information and resources to empower them to join us in this work. And we're excited to take these efforts online with our S.C.O.P.E series. So today's talk features Lisa Breuil, who will discuss health at every size. Lisa is a clinical social worker and fat activist. Since 2003, she has been a psychotherapist doing individual and group work in outpatient psychiatry at Massachusetts General Hospital's West End Clinic. Her specialties include co-occurring addictions and eating disorders, trauma, and body image distress, and helping people with new onset substance use disorders and compulsions following weight loss surgery. She is an expert on weight-inclusive treatment and the impact of weight stigma on health, and has presented at conferences, grand rounds, and other events. Lisa is a member of the MGH Psychiatry Department's Center for Diversity and is a member of the Academy of Eating Disorders Diversity, Equity, and Inclusion Advisory Board. She also has a private practice in Salem, Massachusetts, where she provides individual and group therapy as well as clinical consultation and supervision. Mostly important to her, Lisa helps people live peacefully in their bodies by improving self-care skills and teaching people how to navigate our challenging body culture. There will be a Q&A session at the end, and I encourage you all to please submit your questions throughout Lisa's presentation by clicking on the Q&A icon at the bottom of the screen and typing in your questions. You may also change your name to anonymize yourself if you'd prefer to ask a question anonymously. We will do our best to answer each submitted question, and we're really appreciative of your time for joining us today, and especially to Lisa, who's going to be leading this discussion. So I'll turn this over to you, Lisa. Thank you.
Thank you. I'm absolutely delighted to be here, and I'm going to pull up my slides. So I'm going to be doing a very brief introduction to the Health at Every Size model. First, I want to do a land acknowledgement. So I'm honored to give this talk today on the traditional land of the Wampanoag people, whose history here goes back at least 30,000 years. I wish to acknowledge them as the caretakers of this land in the past, here in the present, and into the future. And for people that are interested, the Wampanoag tribe has a project, the Wampanoag Language Reclamation Project, which you can donate to if you're interested in helping them keep their language alive and available for future generations. So I also want to acknowledge, the privileges. One of the things that the Health at Every Size model tries to help people with is understanding intersectionality and how different privileges and oppressions intersect in people's lives. So I really want to make sure I'm acknowledging the privileges that I have. So I'm white, Christian, cisgender, straight, highly educated, financially stable, able-bodied. I'm sure there are other ones as well. Because of those privileges, I get to do things like speak to Harvard medical students. So I think it's really important to acknowledge that, my learning and my understanding of things comes from who I am and the privileges that I have. So the first thing I want to say is introduce myself as a fat person. The word fat is a very controversial word in our culture. Many people see it as an unacceptable word, an insult, but an increasing number of fat people like me are reclaiming that word and use it as a neutral descriptor. So in the same way that I might say I'm a white person, I have gray brown hair, I'm fat. I'm not being cute or self-deprecating. I'm using it in a positive or neutral way. And I would like to, if that word makes you uncomfortable, I'd invite you to ask yourself about that, be curious about where that's coming from. And I'm certainly not asking you to start using that word if you're not comfortable using it. But I want you to be aware that it is, it's a word that's whose meaning and whose use is changing. And I also want to make sure I'm really clear that I reject obesity rhetoric, the whole construct of obesity. The word itself references illness due to overeating, that someone has a condition because of their body size. And I'm really clear that my body size is not an illness. So I do use the word obesity when I'm talking about the literature. It's very difficult to sort of look at the literature and discuss it without using that language, but fat or larger bodied is highly preferred. And if you want to learn more about that, there's a great paper, and I included this in the links that I sent for all of you to have afterwards. There's a really great paper that sort of talks about why this language is problematic and why the word fat is more preferred by a number of people. And lastly, I just want to say, please feel free to ask me questions, whether here or later on. I'm happy to, sometimes people will get in touch with me after a presentation. I understand, I know that a lot of what I might be saying today is going to be in direct contrast to some of what you're learning in medical school, or you believe as someone who lives in our culture. So, I'm perfectly comfortable with questions or skepticism, and whether now or later, I'd love to hear from you. So let's first talk about what health at every size is, because it's a little bit, it can be confusing for people because it's a social movement. It's also a specific weight inclusive treatment approach, and it's an orientation. So, I describe myself as a health at every size oriented clinician, for example. So it's sort of a way of thinking about bodies and health. And just to be clear, it's not the same thing as size or fat acceptance, okay? Fat acceptance is specifically a civil rights movement, and promotes the idea that people have the right to exist in bodies of all sizes without shame, stigma, bullying, or oppression, okay? Health at every size is an evidence-based paradigm. It recognizes that health is not an obligation and not completely in our control. And the focus with health at every size is on health, not on body size manipulation, okay? So size acceptance can exist without health at every size, but health at every size cannot exist without size acceptance. It's built into the model. So, what I'd first like to start with is talking about diet culture, okay? And it's really important for everyone to understand that there's an enormous amount of money to be made maintaining diet culture. $72 billion is the amount of money being made in the weight loss market in the United States. And so there's a lot of money at stake when we look at the resistance to examining diet culture. So what is diet culture? So diet culture disconnects people from their internal body cues about what their body needs to eat. For example, it validates and encourages disordered eating. It puts food into, good and bad, healthy, unhealthy, clean, not clean categories, which is really problematic. It privileges thin, fit, and abled bodies. It creates fear and loathing of fat or disabled bodies. It encourages discontent. It encourages perfectionism. It centers the problem, whatever that is, on the individual and their body. Diet culture is where the whole "I feel fat," today comes from. It posits that food must be earned through righteousness, in behavior and in the size of your body. It posits that the body must be subjugated to the will, that your body is something that should be and can be controlled at all times. And it intersects with racism, ableism, and other oppressions. Okay, we're all swimming in diet culture. You know, many people, when I first talk about this with them, like they've never even thought about this before. Like we're so embedded in it that we don't even see it. We don't even see it as something that is imposed. You know, people treat it like a natural law rather than understanding that it's culturally um, uh, imposed on us rather than just something that's natural and would be there whether we created it or not. So when you have an agenda around someone's weight, you're colluding with diet culture. Okay. You are enabling diet culture to continue to flourish. So diet culture and weight stigma feed one another. Okay. It's like a vicious cycle. And you know, it goes round and round basically. So let's talk about what we mean by weight stigma. So weight stigma is shame placed on individuals based on weight or body size, judgment and biases predetermined by weight, body size, and lifestyle, and judgment of someone's character, their work ethic, their personality based on their weight. It shows up in lots of different ways. People suffering prejudice and discrimination because of the judgments made about their weight, inequalities in the employment, healthcare, educational settings due to negative stereotypes that fat people are lazy and incompetent. And it can be communicated both directly and indirectly in, you know, sometimes in very subtle ways. So some weight bias as opposed to weight stigma. Weight bias is an internal attitude. Bias has to do with how we think and what our beliefs are. Okay, so an example of explicitly expressed bias, you know, consciously discriminating or bullying people. You know, an example would be not inviting a larger neighbor over because you don't want to be seen with fat people. You don't want people thinking you're friends with this person. Implicitly expressed bias is sort of unconscious beliefs, like assumptions, assuming all large people wish that they were thin, or this large person must be unhappy. Or what I, as a mental health clinician, sometimes what I come up against is people who think that someone who's fat must have had a trauma history because that's why they're fat, because they were traumatized, things like that. We know that looking at the literature, weight discrimination is a major form of bias. Kids who are teased report more suicidal thoughts. Fat kids are liked less, chosen less as friends, rejected more often by peers than average weight youth. And this is interesting because right now, when we think about how the bully gets portrayed in television or movies, oftentimes a bully is shown to be this fat kid. And in reality, that's the kid that's most likely to be bullied rather than be the bully. A survey of parents found that 1 in 10 would abort a child if they knew it had a genetic tendency to be fat. And young girls have indicated in surveys that they're more afraid of becoming fat than they are of cancer, nuclear war, or losing their parents. And as an eating disorder clinician, I can tell you that we are seeing an anti-fat bias show up in children as young as 3 and 4 years old. These days, it's the age at which children are aware of body size differences, that they're important and that they matter, is getting younger and younger over the past 20, 25 years that I've been doing this work. So this is an example of just free range aggression towards fat people that you could find in social media. This is from a tweet from years ago that Jeffrey Miller, who's a psychologist, posted. And he got in trouble for this, actually. He ended up getting in trouble and had to shut his Twitter account down because of this tweet. But it does not take very much work to find anti-fat people comments all over social media. This is, if you are on Twitter and the hashtag diagnosis fat, I'm not going to read these out loud, but I'm going to give you a moment to read them. These are examples people posted of ways that that anti-fat bias has shown up for them or people they know in medical settings. I can't tell you how many stories I've heard from people of tumors that get missed, cancers, broken bones, neurological issues, because the doctor just focused on somebody's weight, pericardial issues, all sorts of stuff. And visits to doctors, having to go to see a doctor can be a very traumatic event for a fat person. I know people who, they have panic attacks almost at the thought of having to go see a doctor because of things that they've experienced in the doctor's office. So looking at the literature, I'm just going to very quickly show you a few studies, but there's growing robust literature looking at anti-fat bias amongst medical professionals and doctors. This one looked at lower quality of care. The doctors viewed fat people as significantly more negatively than thinner people. Physicians build less rapport with obese patients. There's research showing that doctors touch fat people less when they examine them. New mothers who are in larger bodies get less help breastfeeding than thinner moms. Lower respect for patients. And this is something that fat people experience all the time and know that this is happening. This also holds true for nurses, dietitians, personal care assistants, basically all the different clinical specialties. It holds pretty much across the board. And even with health professionals who are in the bariatric industry, hold these same anti-fat biases. So how does this impact health outcomes? Looking at health outcomes. Increased BMI is associated with an increase in the delay and avoidance of healthcare. Again, people are dreading having to go see the doctor, dreading the usual conversation about their weight, even if they've gone in there for strep throat or something. We know that social stigma is as significant as socioeconomic status in influencing population health. And fatter people have a harder time getting health insurance. That's not as bad now with the Affordable Care Act, but a lot of people right now that I know are really scared. What happens if that goes away? Because being fat is considered a pre-existing condition. Drug dosages are often incorrect for fat people, particularly cancer treatment. Incentivizing workplace wellness can increase stigma for fat people, and weight stigma decreases activity and exercise levels. So we know that weight stigma and poor body image decreases good self-care. And a lot of the work that I do with people is around helping them take better care of themselves despite the stigma that they're dealing with, learning how to almost inoculate yourself against some of that stigma and reduce your internalized stigma so that you can take better care of yourself. And these, just on the left, Reagan Chastain, who is a fat activist and as well as I am, creates these cards that people can bring to their doctor's office when they don't want to be weighed. Okay, because being weighed can be really triggering for people. So the psychological consequences of weight bias include depression, anxiety, low self-esteem, suicidal acts and thoughts, and poor body image. And all of these contribute to poor health outcomes and difficulties in good self-care. And then it's really important to remember that weight bias intersects with all sorts of other oppressions. when thinking about people. You know, most people are not just one thing. So when we are, you know, very correctly concerned about racism, if you're not also addressing weight bias and weight stigma, then you're leaving people behind, because, you know, just dealing with the racism is not sufficient if someone is also queer or if someone also is living in a fat body. So, and there's a really great new book out. I highly recommend it. Sabrina Strings, who I think is a sociologist, wrote a book, Fearing the Black Body, The Racial Origins of Fat Phobia. And she really goes into the history, going back into the 15 and 1600s, and looking at how this thin ideal was a way for the white ruling class to separate themselves, to create the other, you know, unorganized, undisciplined Black people. You know, that body size was associated with appetites that were out of control. So, you know, all of this, we know that all of this is connected. And it's also really important, from the Health at Every Size model, understands that healthcare that ignores social justice is malpractice. So you really have to be looking at and working with patients in the context of their lived lives. And medicalizing and pathologizing normal body differences does real harm. So just as an example, you know, this is a great example, this article, looking at fat people in surgery. There's a lot of trauma that happens when fat people are denied surgeries because of their body size. And this is a really great example. This article talks about a woman who was told, you know, she wouldn't be able to walk at 35 years old, since she was about age 10, that someday she, you know, and they were recommending weight loss surgery to her. But she decided to, and when a doctor told her that she couldn't have knee replacement surgery until she lost weight, she, you know, did not want to go along with that. So she instead learned about how obesity, diabetes, and asthma affect surgical outcomes, and prepared herself for battle. You know, got prepared, did some reading, went in ready to talk to the doctor, because, you know, she was at the place where she couldn't walk, and she, you know, and the doctors, this is what typically happens, is a patient is told, well, you need to lose weight, you need to be more physically active. And the patient is like, well, I would like to do that, but my knee doesn't work anymore. So people are put in this really tough position. And, but she finally met a doctor who was willing to operate on her at her weight. And as it notes, even though the headline says obesity can make surgeries more dangerous for patients, down the bottom it says the patient had both knees replaced, both times without complication. So a lot of assumptions get made about how fat people are going to do, that aren't necessarily validated by actual outcomes. An example of how this intersects with other issues is for trans folks. More than 25% of transgender people seeking gender confirmation surgery are considered too fat to have it done. Okay. And so people are put into this position where they're told they have to lose weight in order to meet criteria for the surgery. But because weight loss is just about impossible over the long time, people end up stuck and not able to get the treatment that they need. And this is, I asked my friend and colleague, Laura, if they would provide their thoughts about this. So I want to read this out loud because I think it's so important. The impact of fat phobia on the trans community is heartbreaking. Countless trans people are starving themselves in their attempt to access surgeries that are necessary for their physical and emotional well-being. To be honest, I suspect that my friend who died following their top surgery was made more vulnerable to the post-surgical infection that led to their death because of their history of eating disorders. The gatekeeping that prevents fat trans people from accessing medical transition is killing my people. That is not an exaggeration. Okay, and I think it is important to think about, you know, dieting, calorie restriction is malnourishment. And we are, in my opinion, we are increasing the risk for post-surgery complications when we're sending people into surgery when they've been restricting and under eating. So we have to do better, okay? And that's what I'd like to talk about next, is how we can do better. So health, this is where the health at every size piece comes in. When I talk with medical professionals, a lot of times what I'm hearing more and more these days is, yeah, we get it. Dieting doesn't work. Yes, understood. But what are we supposed to do? So health at every size gives people a model for what they can do. Okay. So the other piece that I think is helpful to understand is we're in the middle of a paradigm shift right now. Okay. We're moving forward in our ways of thinking about weight and bodies. And I'm part of that, hopefully, helping people move forward into a more weight inclusive way of thinking. Because right now what we have is 60 years of this failed paradigm. This is from Albert Stunkard, 1958. Most obese persons will not stay in treatment of obesity. Those who stay in treatment, most will not lose weight. And of those who do lose weight, most will regain it. Okay, this is still true. This has not changed. All right, there is no evidence that it has. So what you have to understand is most obesity prevention interventions are experiments based on unproven assumptions about weight and health. So this is again, this is in the links that I sent. This is a paper, Medicare's search for effective obesity treatments, diets are not the answer. So this is researchers looked at just every study they could find about every diet they could find, looking at overall quality of evidence across outcomes. What they found was that dieters who manage to sustain a weight loss are the rare exception rather than the rule. And dieters who gain back more weight than they lost may very well be the norm. And that's called weight cycling. People lose 20 pounds and 3 years later, they've gained 32 pounds back. And then they try again and they lose 40 pounds. And then 2 years after that, they've gained 45 back. So, one of the best predictors for weight gain across adult lifespan is a robust history of dieting. Okay, here's something very recent. This is just from January of this year. This looked at a review of almost 25,000 studies of obesity treatments going back to 1984. And they wanted to just include the high quality studies. They wanted at least a 3-year follow-up, at least 5% of body mass had to be lost, no interventions in the follow-up period. Prospective design, so really looking at everybody, and less than 30% dropout. And of the almost 25,000 studies, they could only include 8 that met all these criteria. So that right there speaks to some of the issues with the literature around weight loss. But as you can see, here are they looked up to 5 years after intervention. Here's the treatment period, and clearly everybody lost weight. But as you can see, everybody regained weight, and some people regained more than what they originally weighed, right? And so these were the 8. At most, I think the very low calorie hospital diet, hospital recruitment, they had like a final weight change of 8% and of 35 people. So not impressive. And the other thing I think it's really important to remember, and this is from Fiona Willer, who again, you'll have information about her work, is, the way a lot of times that weight loss research is organized, you can have an outlier who responds really well to the intervention that pulls down the average. And so you end up with not good information. You got one person that lost a ton of weight and the rest of the people lost a little bit of weight, but it looks like more people lost more weight. So the issues with weight cycling, sometimes, again, one of the questions I hear is, well, I know, but if it works for even 1 or 2 people, shouldn't we be encouraging people then to try and lose weight? Because those couple of people will lose it. Well, unfortunately, this is not a benign intervention. when people pursue weight loss and end up weight cycling, you have a lot of issues that can happen, a lot of problems. All sorts of health outcomes, increase in rates of cancer, all-cause mortality, immune function goes down, bone mineral density goes down, chronic inflammation gets worse, rates of gallstones go up. There's all sorts of, Jess Campbell, who's a student who, I think she's in Canada and she's currently in medical school, does some great infographics and on Instagram. Just looking at cardiovascular risks, increase in CVD mortality, heart attacks, chronic inflammation, hypertension. So this gaining weight, losing weight, not good for us. And it's really important when you look at the data on fat people and health to be thinking about how much of that is just living in a fat body, how much of that is this person's history of weight cycling, how much of this is the stigma they live with, because all of that plays a role. And then when we look at the effects of calorie restriction on the body, we see, chronically under eating is not good for people. And there's also any number of mental effects as well, mental health effects as well, which I don't get into here. So the current dominant health paradigm is this weight-centered health paradigm, also known as the weight normative. And again, diet culture feeds that and supports that. Health at every size is a model from a newer paradigm, which is the weight inclusive paradigm. So again, this is a paper that I included in the links that looks at explains the context of the weight-centered paradigm, the critiques, the consequences. I highly recommend it. It's a beautifully done paper. And these are some of the tenets of the weight-centered, the assumptions that get made that we all believe, because this is what we're told is the truth, okay? And the health at every size model really pushes back and asks for the real evidence around these beliefs. So let's talk more specifically about what health at every size is. So this is the Association for Size Diversity and Health, is the professional organization for the HAES model. It's an international organization. There's any number of clinicians, doctors, researchers, therapists, dietitians, public health folk, growing number of people who use this approach in how they do their work and care for people. So let's talk about the HAES principles. And again, I just want to say this is a brief overview. I literally have done entire day workshops on the principles. So this is just a very quick run through. So the 5 principles include weight inclusivity, health enhancement, respectful care, eating for well-being, and life-enhancing movement. Okay. So weight inclusivity is about accepting and respecting the inherent diversity of body shapes and sizes and rejecting the idealizing or pathologizing of specific weights. Okay. So weight neutrality doesn't cut it. It's not about, I don't see people's weight. Okay. In the same way that when people say, oh, I don't see color, we're all the same. Like, that's not very helpful, because what color people are, what race they are, absolutely has an impact on their health, right? And on their life. So we don't want to pretend that that isn't real. So in the same way, it's important not to pretend weight isn't there, but to acknowledge it and affirm it, and understand how people's weight impacts their health and their well-being. So these are just a few, images from different fat positive resources and websites. And, I just want to say, it's one of the things that I do for folks is I introduce them to what's called the fatosphere, introduce them to size positive, fat positive resources, because it can be really challenging for a fat person to see a positive, affirming image of another fat person. Most of the time we are exposed to thousands of images every day, many of which are very fat shaming and depersonalizing. And so it can be amazing to watch when people get to see people that look like them, who look like they're happy, who look like they're healthy, who look like they're living life. These are some, again, these are some of the images, Olympic athletes who are in larger bodies, for example. Also, I think it's very important to make the point, sometimes people, posit that if everyone was doing it right, if everyone was eating well, if everyone had access to healthy foods, if everyone had access to safety, if we didn't have trauma, we'd all be thin, and that's just does not hold up. It doesn't hold up to the historical record. There have always been fat people, and there will always be fat people, right? Because this is the bell curve, and we know just like there are people that are quite thin, and that's where their bodies want to be, there are also people whose bodies want them to be quite fat. And most of us are somewhere in the middle. Now, we can have a discussion about why right now there seems to be more fat people than there have been in the past. But the idea that if we're all doing it right, there would be no fat people is very harmful to fat people. We're supposed to be here. This is Happy Fat Trans Man, who I follow on Instagram, who's a lovely person. I just love this. This post that he made. It's also, I want to make sure people understand that the health at every size model is not against weight loss. Sometimes when people are taking care of themselves differently, some weight might come off, and that's okay. That's not a problem. What we don't want to see is centering the pursuit of weight loss. Making weight loss the point is what is so harmful to people. So just, things you can tell by looking at a fat person, it's just something to keep in mind. So health enhancement is looking at supporting health policies that improve and equalize access to information and services and personal practices that improve human well-being, including attention to individual physical, economic, social, spiritual, emotional, and other needs. So, health is complicated, and the HAES model understands that. So we're all entitled to make up our own minds about what health means to us, and to prioritize our health as it makes sense to us in our lived lives. And, it's really important that we all are able to respect people's priorities. And, again, what our medical professional might think should be the most important thing might not be what a patient thinks is the most important thing. And it's important to make sure that patients are informed and they're making informed decisions, but respecting what their goals are. We want to make health at every size stands in opposition to healthism, okay, which is the belief that good health is an individual's responsibility and is within an individual's control. So HAES understands that, some people, no matter what, are not going to meet our current definition of physically healthy, and that's okay. So it's really recognizing the things that we have some control over, like certain health behaviors, and helping people understand the things that we don't. And helping people stop blaming themselves for the things that they don't have control over. So the health at every size model is trying to move more towards health equity. The next tenet is around respectful care, which is acknowledging our biases and working to end different kinds of discrimination, and understanding that socioeconomic status, race, gender, sexual orientation, age, and other identities impact weight stigma. So not leaving these other oppressions behind as we're helping people deal with weight stigma. Okay, so again, making sure that we're understanding the intersectionality, and that it's for everybody. It's for everyone, and you don't have to be fat. Many people I work with and many health at every size experts are not people that live in fat bodies, but this approach helps everybody. So just, I'm not going to go into detail on this, but just looking at allostatic load, which is the cumulative dysregulation of biological systems with prolonged and poorly regulated allostatic responses. So the literature looking at allostatic load found associations between it and physical and mental health and all-cause mortality. So basically, the more oppression someone is dealing with, the more stress, the more likely their health is impacted, regardless of their individual behaviors. And we know that this research looked at perceived weight discrimination doubles the 10-year risk of high allostatic load. And eliminating weight stigma may reduce physiological dysregulation. So again, when you're looking at the research and the assumptions that get made about fat people, again, you have to ask yourself how much of that is about the adipose tissue and how much of that is about all the stuff that comes with living in our culture in a body with a lot of adipose tissue. So again, making people feel bad about their bodies makes it harder for them to take good care of them. It leads to disconnection and avoidance. And as Marilyn Wan says, you can't hate people for their own good. It doesn't work. So how people think about their bodies and what they believe about their bodies matter. And I'm not going to stop for these research slides because I want to wrap things up, but there's some really good research looking at how people think, independent of BMI, impacts their health, how they think about their bodies. Okay, including, increasing the risk of diabetes, for example. And adults with greater weight satisfaction report more positive health behaviors and have better health status, again, regardless of BMI. Okay. Eating for well-being, promoting flexible, individualized eating based on hunger, satiety, nutritional needs, and pleasure, rather than any externally regulated eating plan focused on weight control, also known as dieting, right? So many HAES oriented people use intuitive eating. You don't have to, but this is a specific model helping people reconnect with their individual hunger and satiety cues. But again, it's really important to look at, the health at every size approach encourages any recommendations regarding eating or diet take into account people's individual preferences. And it's really important to ask the question, who in our culture gets to decide which foods are healthy and unhealthy? Because it's usually very privileged white people who designate this is okay, this is not okay. This was not acceptable, now it is. And Michael Twitty's book, The Cooking Gene, is a beautifully written, lovely book. I follow him in social media as well. He's he is a food historian that I've learned a lot from. Diet culture is colonialism. And centuries ago, quinoa was taken away from native peoples. They were forbidden to eat it anymore because the thought was the Europeans that came in and colonialized South America and Mexico believed that if they got them to eat like Europeans, they would be less, quote unquote, savage. And so now we've decided, white influencers have decided that quinoa is a valuable grain and appropriate to eat. And so now there are native populations in South America that they're priced out of their own staple grain because of white people. So again, looking at all of this and how it influences people's health and how they feel about their bodies. So trying to knock off the food policing, and when someone tells me that this was their lunch, I'm absolutely going to be curious about why that is, but I'm also going to remember that in the context of their lived lives, that might make sense for them. And not to assume that this is not about the fact that they don't care about themselves or they don't want to be healthy, but that there might be, this might work better for them for some reason. And to be listening and open to that. So again, not bad and good fooding it, for people. Adding to people's shame and food policing is not helpful. And the last one is life enhancing movement, and then I'm going to stop talking. So supporting physical activities that allow people of all sizes, abilities, and interests to engage in enjoyable movement to the degree that they choose. And that's a really important line. That's going to look different for different people and different circumstances. And I know right now what I'm working with lots of people is lots of anxiety and shame because of COVID. They are not as physically active and they feel guilty about that. So I'm doing a lot of work with lots of people around sort of like not being mean to themselves about that and finding other ways that maybe they can move their body that makes sense for their current life circumstances. Okay, so what we try and do with Health at Every Size is help people find physical activities that are pleasurable and sustainable rather than focused on weight loss. And again, these are just some examples of fat people doing stuff, which again can be really helpful for people to see. It can be very challenging for a fat person to get to see other fat people being physically active or doing yoga, so it can be helpful to help people get connected to fat resources. This is Rachel S.C.O.P.E. She's local here in Boston, but these are just some examples of some amazing fat yoga teachers. 300 pounds and running, great Instagrammer to follow. But I want to show you, remember I showed you that picture of the Twitter, the person who tweeted the mean comment about fat PhD candidates. So this was a website that was created, it's still there, in response to him that showed, I think they've got about 100 fat people with PhDs to say, yes, we're here and we exist. So that's a great example of some fat activism. The last thing I'm going to say is to please learn about Health at Every Size from actual HAES experts, people from these different organizations, and to please learn about fat people from fat people who don't think we're sick, who don't see themselves as sick or diseased because we're fat. Okay. It's really important to remember, I work at a substance use disorders clinic. If the only information I got about alcohol was based on my work, I would think that alcohol was incredibly dangerous and nobody can use it without getting into trouble. But we know that that's not the reality. So it's the same thing. If the only fat people are people that are showing up in your office because they've got a medical issue, or you're only learning about them from bariatric professionals who who live in the obesity construct that fat bodies need treatment, then you're going to get a skewed view. So trying to widen your lens so you're seeing lots of different kinds of fat people. And I'm going to end there. I know I've gone a little bit. I wanted to stop about 5 minutes earlier.
No, that was wonderful. Thank you so much. And questions are already starting to come in. So
okay.
I just want to remind folks, please feel free to either use the chat feature. You can send questions to the panelists, or you can submit questions in the Q&A button at the bottom. But let me get to some of the ones that have been submitted. So you referenced at the end about how COVID-19 brought about, a lot of anxiety for patients that you're working with. So can you talk a little bit more about that, and also, something practical that health professionals and trainees can do on behalf of their patients now, like given this white noise of stress that COVID-19 has brought all of us?
Sure. So, what happens is, especially for fat people, we've been trained to assume that we're the problem. So, I will oftentimes, when I work with people, they feel like, well, if I'm not out running the Charles River Loop, then I'm no good. I'm not. And so one of the things I work with on people is finding like sustainable, regular things that they can do that work in their life for their body. So like I'm never going to be a runner, never been a runner, never going to be a runner, but I love kettlebells, and so finding things that work for people. And so with COVID, as it's been incredibly disruptive, and people's exercise, routines have changed, or what they're realizing. Like I certainly realized, like, wow, I did a lot of walking. I didn't realize I was even doing. Now that I'm home all the time, I don't feel that good. So I had to find ways to increase my physical activity. But what happens is, patients blame themselves. They should all over themselves. I should be doing this. I should be doing that. And instead, what I try and do is help them think about, okay, but we're all under a lot of stress. Of course, your routine is different. Is there some way that we can introduce some physical activity that will work for your current life circumstance? And you don't have to be so mean to yourself about it. So one of the best things I think doctors can do is really kind of almost like give people permission. Like, it's okay to do what you can. Anything's better than nothing. If all you can manage right now is a 10-minute walk in the morning because you have to get back in the house because your kid needs help on Zoom, that's okay. Your body will use that 10 minutes, and if you can add in another 10 minutes at some point, that's great too. But lots of times, especially fat people, they do a lot of stereotype management. They're very anxious about what their doctor is going to think about them. So when doctors can say, it's okay, I get it. It's really hard right now. I'm struggling right now too. Even if you get in a 10-minute walk, even if you just, do a yoga class a couple of times a week, that's better than nothing. That kind of like messy middle, making that okay.
That's really helpful. Thank you.
Mhm.
We had a question come in through the chat. What is your suggestion when someone comes to you asking for your help to lose weight?
Mhm. So the first thing, and because I get that all the time, I do eating disorder work. The first thing I do is validate that, of course, you want to lose weight. Who would want to be fat in our culture? So I validate that that's completely understandable. And then I let them know that there is no way that I know of for anyone to lose weight and keep it off. That 95 to 98% of the time, according to the literature, the weight's going to come back on, and about 50% of the time more weight will come back on. So I sit with people around how frustrating that is and how stressful that is, and I ask them why they want to lose weight. So sometimes it's, well, I really want to look, I want to be able to, I want to wear a size 8 again. Lots of times it's, well, my blood pressure's out of control, or my doctor says I'm going to get diabetes if I don't lose weight. And so then I say, oh, okay, well, there's certainly things that we can do to increase stamina, strength, flexibility, improve your heart rate, improve your blood pressure, that have nothing to do with weight. We can look at your eating, we can look at your stress, we can look at your physical activity, and you can, by changing behaviors, you can improve health markers. And if some weight comes off, that's okay. That's not a problem. But if we're just going after the weight then and making it all about the weight, then we're setting people up to fail. Because when we lose a lot of weight, our body responds in very specific ways, decreases our metabolism, increases the salience of calorie dense foods. There's a huge drive to put that weight back on. But if we make it about keeping your blood sugar where you want it to be, feeling good and energized in your body, like, those are things that are much easier for people to actually maintain. So I try and shift the focus over there.
That's really helpful. And I'm sure that's helpful for the folks in the audience who are practicing providers and trainees. Sort of reframing that for your patients is really helpful.
Mm-hmm.
Another question came in anonymously through the Q&A, and it's, how can I, a person in recovery from a restrictive eating disorder, combat my internalized fat phobia?
That is a great one. And I'm in recovery from an eating disorder as well. I've been in recovery for about 20 years. And, the best thing that I find is community with with other, people who are in recovery and working in these fields, to, um, um, remind myself that, and be connected with other people that are sharing this struggle. And being connected with, and looking at, this is why the fatosphere, that can be the fat positive resources out there, can be so helpful. There is research showing that when people are regularly exposed to aspirational pictures of fat people, like fat people that look healthy and happy and living life, and you get exposed to these people, that our perception of what's acceptable or even attractive shifts. So, you know, and certainly I think I can say working at a hospital, it's very fat phobic. There are constant messages about how we're all supposed to be thin. And so I think medical providers in particular can really struggle to get out of that mindset. So getting more connected with weight inclusive, health at every size, resources. There are doctors like Jennifer Gaudiani, Dr. Leslie Williams, who just presented at Harvard Chan School, who are, you know, there's a growing number of medical MDs who work from this perspective. And I think being connected with those folks can be really helpful.
Great. I'm going to try to combine a couple questions because they seemed sort of similar in theme.
Sure.
One came in through the chat and asked, I think you addressed some of this in the question before the previous question, which is, what if someone is fat and has diabetes, high blood pressure, and liver issues? Would you recommend bariatric surgery for this person? And I think a connected question that came in through the Q&A is, you know, what do you think about where we are in history right now, and how, according to this question that came in, there are more people in the US who are fat than in other times in other places. And I think they're connected because there's this knee-jerk response sometimes of like, let's fix this and let's recommend bariatric surgery. So how would you respond to some of these questions?
So first of all, yes, there are more fat people now, but we're not sure why, and that's really important to know. Other mammals are also heavier now than they've been. Laboratory animals are fatter now than they were 20 years ago, and they have some of the most restricted, you know, organized diets in the world. So, you know, we're not sure about why exactly. There are lots of theories about it, including, you know, our food environment. So that might be true. We're also taller than we've been. Our feet are bigger than we've been. Our hips are wider. So, you know, it's interesting how we don't talk about a height pandemic. You know, oh my God, people are on average 3 inches taller than they were in 1820, you know, but we're panicking because people are fatter. And I think the average size difference is like 11 pounds. The people like me who are supersized, we're still quite rare. So that's one piece. I think it can be helpful to be curious, but we don't have to pathologize the fact that people are fatter. And the other thing is that you can help people. There is no health condition that just fat people get. So if you have a thin person with diabetes or a thinner person with diabetes in your office, what would you be telling them to do? Tell the fat person to do that. You know, they can all be addressed. And again, it's kind of like people say, yeah, but you know, they lose weight. It's like, okay, but lots of people do those same health behaviors. They don't lose weight, but their numbers still get better, but they don't get the attention. Like we've got this attachment between weight and these behavior changes. And I do not recommend bariatric surgery. I think chronic malnutrition, which is what bariatric surgery creates, is not good for anybody. People will lose a massive amount of muscle as well as fat tissue. Risk of suicidality goes up. Eating disorder behaviors increase. Substance use issues increase. And we know from the literature that fat people that are interested in bariatric surgery tend to have the highest rates of internalized weight stigma. So these are people that are just overwhelmed by living in a fat culture, have really poor self-esteem. I don't think desperately, you know, someone desperate to get out of their fat body, I don't know that they're in the best mental place to be making a decision that's going to permanently alter their ability to absorb nutrients for the rest of their lives. And I think a lot of people, you know, the surgery they don't end up where they don't end up where they thought they were going to after the surgery. So yeah, I don't recommend them. Of course, you know, people have the right to make that decision. My hope is that people go into it fully informed, really understanding what the long-term consequences can be if they're going to make that decision. But it's not something that we recommend.
Yeah, Thank you.
Mhm.
And if folks have one more minute, I did have one final question, which is, what's the one takeaway you would like people to have from this session?
The one takeaway, if you get nothing else, is don't make any assumptions about a fat person who's sitting in your office. Don't assume anything about what they eat, how physically active they are, what their health problems are. Do your best and to come in from a neutral place. Be aware and to be aware of your biases. We all have them. I have them. And so to make sure that you're doing your best to be aware of them and don't make assumptions.
Wonderful. Thank you so much, Lisa.
Oh, it's been a pleasure.
Thanks for staying on a little bit longer so that we could squeeze in a few more questions. And thanks to everyone who tuned in for this live as well. We have recorded it, so we're going to be posting that on our center's website, which is primarycare.hms.harvard.edu. And I think this is a great resource to share with your colleagues and to start, continue initiating these conversations with patients and with other providers. So again, thank you everyone for the time, and a special thanks to Lisa. And we hope you all stay well during these COVID times.
Yes.
Take care.
Okay. Bye-bye.